Welcome to Bullet Point Nursing. My name is Dr. Goldstein, and in this lecture, we're going to go through respiratory or pulmonary pharmacology. Now, we're sort of dividing this up into upper and lower respiratory. In lower respiratory, which is what this video is, we're going to discuss essentially asthma and COPD medications, which is going to be what today's lecture is, with the addition of oxygen. We're going to have a separate lecture, also sort of a pulmonary respiratory lecture, but that one's going to be upper respiratory, which is essentially cold and cough type symptoms and the medications for that, which is going to be most of your over the counters. So let's jump into today's lecture. And anything to do with the airway, we have to start with oxygen. Oxygen is a prescription medication. You can't just go to Amazon or Walmart and buy oxygen without a prescription. That being said, in the hospital setting, you cannot give oxygen to a patient unless you have orders. That's really a moot point because every hospital in the country, at least that I've ever worked with, has standing orders that allows anyone to give oxygen under the correct circumstances where it's appropriate. So that sort of takes away the restriction around oxygen. However, do keep in mind, especially as a nursing student and for nursing examinations, oxygen is a prescription medication. Oxygen comes in a variety of routes: nasal cannula, simple face packs, non-rebreather. I'm sorry if I'm repetitive on this, but these are all fair game questions for a pharmacology respiratory exam. Room air oxygen has an FiO2 of 21%, which means that every time we take a breath, roughly 21% of that is going to be oxygen. The other roughly 79% of it is going to be nitrogen and other substances. The goal of oxygen administration is to improve a patient's arterial oxygenation, meaning to improve the amount of oxygen that makes its way all the way into our hemoglobin, into our blood, so that it can eventually make its way to our cells. Now, a few more things to know about, and then we'll move on past oxygen. A nasal cannula increases the FiO2 by approximately 4% per liter. So if you put a patient on 2 liters, that's 2 times 4, that's 8. So 8 plus the 21, instead of them breathing 21% air, now they're breathing 29% air. Again, that 8 plus the 21. A BVM, or a non-rebreather that's connected to high flow O2, would get the patient's FiO2, the amount of air that they breathe, how much of that is oxygen, and BVM or non-rebreather to get it all the way up to almost 100%. A nasal cannula can only be set at rates of 1 to 6. A non-breather can only be set at rates of 10 to 15. There are exceptions to the nasal cannula because there's something called a high flow nasal cannula. I'm not getting into that. Non-breather we just mentioned. BVM, again, should always be set to 10 to 15. Hyperoxia is where a patient gets too much oxygen. Too much oxygen can be harmful. It can cause oxygen toxicity. In a patient that has a hypoxic drive, which we are not going to discuss this today, we have a med-surg respiratory video that you can go and learn about that. But for pharmacology purposes, oxygen is always safe, other than the fact that too much of it can cause oxygen toxicity. And if a patient has hypoxic drive, giving them too much oxygen can cause apnea, it can cause them to stop breathing. Finally, and probably most important, oxygen should be given to a patient that has the oxygen level below normal. In a healthy patient, that's going to be below 94%. In an unhealthy patient, specifically COPD, they may have a different baseline oxygen level. I'm not going to go any further into that. Again, that would be a more adult health med surg question. However, for pharmacology testing purposes, any patient that is hypoxic, meaning a pulse ox below 94%, should get oxygen. Any patient that has a normal pulse ox, 94, 95 or greater, should not get oxygen. Let's jump into asthma and COPD. So asthma pathophysiology is 3 distinct problems. The first is bronchoconstriction. Bronchi, what all of the air that we breathe in and out moves through to get all the way to the end of our lungs. The bronchi become constricted. They become smaller. Next is inflammation. Not only do the walls become smaller, or does the diameter inside become smaller, but the walls themselves become swollen or inflamed, and that causes the inside to get even smaller. And finally, it results in increased secretions. So now that little bit of inside that's left is now filled up with gunk, and now that makes it even smaller. So where someone was breathing through this nice big opening, now it got smaller, it got inflamed, making it even smaller, and finally it fills up with secretions, making the airway passages much, much smaller than it's supposed to be, making it very difficult to breathe. All the drugs that we're going to discuss throughout this video now are to be divided into 2 sections. We have emergency treatment for acute asthma, acute respiratory distress, and then we have long-term management for chronic asthma to prevent symptoms. One is going to be when a patient's having acute issues. One is going to be for chronic management. So the acute medications obviously be oxygen plus A SABA, a short-acting beta agonist, an anticholinergic, that's going to be ipratropium. Steroids, usually something like methylprednisolone and magnesium sulfate. We'll talk about that. For long-term management, we have inhaled corticosteroids. We have the LABAs, the LAMAs, the LTRAs, and a few more. But let's go ahead and let's jump into all of them so that we have time to go through them. First one is going to be the beta-2 adrenergic agonist, much more commonly known as your everyday inhaler. The inhaler has one of two drugs in it. Almost always it's going to be albuterol. There is another medication that it can have, levoalbuterol. The biggest difference between albuterol and levoalbuterol is the cardiac effects, which we'll talk about in just a minute. The mechanism of action of these drugs are beta-2 agonists, which means they activate beta-2. What is beta-2 responsible for? It causes bronchodilation, so it makes the lungs bigger. Asthma made it smaller. These drugs make it bigger. These drugs are used for both asthma and COPD. Remember, when you're giving this to a patient, you're always going to assess their lung sounds before and after. Wheezing is the bronchoconstriction, and when we clear up that wheezing, we get that bronchodilation from the drug. Hopefully, the wheezing goes away. A key test point, when a patient is being assessed for asthma, especially a child, if you hear the wheezing and then you don't hear it, make sure it's not just because it cleared up. Make sure it is just because it cleared up and not that the patient is just barely breathing anymore because they're so exhausted from the asthma that now they're barely breathing. So you don't hear wheezing, you don't hear anything because they're not really breathing anymore. Make sure you know that distinction because I've definitely seen that on pharmacology test banks. So again, these medications are used for asthma and COPD. Now, these medications activate beta-2. If you've already watched other lectures that we have about knowing the different adrenergic receptors, we know that beta-2 makes bronchodilation, which is what we're talking about today, but beta-1 makes the heart beat faster, harder, stronger. Albuterol is meant to activate beta-2, but it does a little bit of activating beta-1. So not only is it going to cause the bronchodilation, it's going to make the heart beat faster, harder, stronger. Because of that, the classic side effects are going to be tachycardia and palpitations. In fact, pretty much everyone who gets a continuous nebulized albuterol treatment is going to have their heart rate go up somewhere between 5 to 10 beats per minute. That is expected. That is perfectly fine. That's tolerable. A patient can tolerate the heart rate going up, even up to 140, 150, 160. That's a heck of a lot better than their pulse ox dropping to 40, 50, or 60. So keep that in mind. It's okay to tolerate that tachycardia. Maybe let the provider know if it gets what you consider out of hand, but almost always airway comes first. Other side effects are going to be hypokalemia and hyperglycemia. Don't mix these up. These are very common test questions. Levoalbuterol is much more expensive than albuterol. It's much less commonly used for that reason. The real reason it's used is because what we just said, that all of these drugs activate beta-2, but it touches a little bit of beta-1, which is the heart faster, harder, stronger. Levoalbuterol doesn't do that as much. So if a patient has a cardiac issue where they need their inhaler, but it would be bad for them to piss off their heart and make it beat faster, harder, stronger, levoalbuterol would be a preferred option. Patient education, this is a big one in pharmacology tests. Make sure you educate your patient on how to use a spacer, when to use it, and the proper technique. I'm not going to go through that here. There are much better YouTube videos for that have tons of cool graphics on how to do it. Please go to one of those if you're not familiar with it. Finally, educate your patient that these medications are taken when they feel symptoms coming on. These are not preventative medications. I'll say that again. Albuterol inhalers are not preventative. They're not for when I'm feeling fine so that I shouldn't get worse. It's only used when you're having an issue, with one exception. And that's this second bullet point here, can be taken prior to exercise, even when you feel completely fine, if you know that your exercise is going to induce your asthma. That would be exercise-induced asthma or exercise-induced bronchospasm. You may see EIB. A lot of textbooks use that. EIB is exercise-induced bronchospasm. And yes, that is the one exception where a patient would take their inhaler, their albuterol inhaler, preventatively. Next, we'd already mentioned that if a patient's heart rate gets up, that's expected. That's not a reason to stop taking the drug. Terbutaline is another beta-2 agonist that can be used for asthma. It's also used in reproductive health. We spoke about it over there. But for right now, just know that it is another drug in this class. When a SABA, meaning albuterol, is taken with another medication, if a patient was supposed to take two medications at once, the SABA always comes first. Why? Because this will open up the airway to make the next inhaled medication more absorbed. Okay, so again, if a SABA is taken with another medication, take the SABA first. I've seen that also in a bunch of test banks. Now, this was the acute medication. Let's pause on the acute for a second and let's look at a chronic medication. So next we have the LABA, the long-acting beta agonist. So this still works exactly the same, except this drug doesn't work in 10 seconds. This drug, not that inhalers work in 10 seconds, but you get my point. The LABAs actually take several weeks to get their full effect. So LABAs are long-acting beta agonists. They do the exact same thing, but this is not your rescue inhaler. This works the same way, but this is for long-term management. This is taken inhaled. This is preventative. This is taken daily, twice daily, to prevent your asthma from getting out of control. And just a note, this does have a black box warning that it's not to be used by itself. It's only to be used with other agents such as an ICS, which we're going to talk about in just a few minutes. Let's go on back to the acute medications and let's go to the next one. The next medication we have is an anticholinergic. That's the drug class. If you've watched our other videos, you've seen that come up a bunch because anticholinergics are used for tons of different things. But right now we're talking about asthma. The drug over here is ipratropium. Ipratropium's brand name is Atrovent, and this is an anticholinergic. So this does two things. If you'll remember from our cholinergic lecture, anticholinergic means anti-rest and digest, which means pro fight or flight. So it's going to push you away from the parasympathetic system, and it's going to push you towards the sympathetic system. Sympathetic system, you should already know, causes bronchodilation. That's why this causes bronchodilation. Plus, bonus points if you remember this, anticholinergics dry things up. That's why it causes constipation and urinary retention. It dries things up. In the case of asthma, we mentioned a few minutes ago that one of the three problems in asthma, it was constriction, inflammation, and secretions. This dries up the secretions. So that's how it helps in a patient with asthma. We use this for acute asthma exacerbation. There is a long-term version of this, and that's called tiotropium. I'm going to talk about that in just a minute. Ipratropium is very often used in what's called a duoneb. A duoneb is a drug that has both ipratropium and albuterol in it. Duo, it has two medications in it, and it's very commonly used for acute asthma exacerbation. I'm not going to get into the details of when a patient should get ipratropium with albuterol versus just albuterol. That's beyond RN level. But just know that it does exist. It's extremely commonly given. Because this medication is an anticholinergic, the side effects are going to be your typical anticholinergic effects, which is going to be the dry mouth, dry eyes, constipation, etc. Now, back to what I mentioned a minute ago, this is an acute drug, ipratropium, but this, just like the beta blocker, also has a chronic, a long-term cousin. This is in the same class, tiotropium. It's another anticholinergic, but this one is referred to as a LAMA, a long-acting muscarinic antagonist. Muscarinic is one of the cholinergic blockers, so it's a long-term cholinergic blocker, aka a long-acting anticholinergic. Tiotropium is one of the drugs that we use for chronic management. It would be another daily or twice daily inhaler that the patient takes. However, this is not used for acute versus the ipratropium, still within the same class, is used for acute. So just to catch up, so far we learned about SABAs and LABAs. One was acute, one was chronic, and now we're learning about anticholinergics and LAMAs, which again are both the same thing, but one is acute, one is chronic. Let's move on to steroids. And again, in steroids, we're going to have acute and chronic. Starting with systemic glucocorticoids, there are tons of different drugs that fall under this. We discuss it in depth in two different videos, the anti-inflammatory video and the endocrine video. I'm not going to put all of it again over here. I'm going to go through this really quick. So steroids are given systemically, meaning PO or IVIM, for acute asthma exacerbation. That's where we can't get immediate control. This does take some time to get effect. It doesn't work in 5 minutes like the albuterol or the ipratropium. So this is not going to help a patient this second, but it'll help them over the next few hours to improve their lung function. However, this medication is given systemically. So if you've watched our other lectures about this drug class, you know that this drug class has tons of negative effects when given systemically. So we don't like to do that. Because of that, we do have an inhaled route that can target just the lungs. But before I get to that, let me clarify. The inhaled route of steroids is not for acute. It is for chronic only. So the PO, or IVIM, the systemic steroids, are used for the chronic, or I'm sorry, are used for acute, versus what we're about to talk about, the inhaled, is used for chronic. One last item, because this is always on test banks. If a patient is getting PO steroids, it must be tapered down. It cannot be stopped abruptly. Now let's jump into ICS. So now we've sort of officially switched to the long-term chronic medications, starting with inhaled corticosteroids, because this is the #1 first recommended choice for every patient who has chronic management, that their PRN albuterol inhaler is not enough. So we start with ICS. This is going to be a twice daily medication. There's fluticasone, there's budesonide. These medications are taken by millions of people every day, and they're steroids. They suppress inflammation. In fact, they're great at it. Because they suppress inflammation, they help reduce the symptoms and the patho of asthma. What do we use it for? This is the first line drug for the long-term chronic management of asthma. Plus, it can also be used off-label for COPD. Throughout this video, I'm really not going to break anything up between asthma and COPD. For pharmacology purposes, we're going to consider them the same. They have a lot of the same pathophysiology, and for pharmacology, they have a lot of the same treatment. Next, this is the first-line drug. I already mentioned that. The onset of this drug takes several weeks. So let me really drill that in. This is not an acute medication. This is for long-term, but it is the best for long-term. Finally, if a patient is taking this, you must educate them to rinse their mouth out after every single dose in order to prevent candidiasis, oral candidiasis, also known as thrush. Okay, so that would be a fungal infection in the mouth that can result from taking steroids. Finally, we have our last drug for acute. Our last drug for acute is magnesium. In this case, it is given via the IV route. This is not just, I'm having an asthma attack, I go to the store and get some magnesium pills. This is a smooth muscle relaxant. So we said that in the case of asthma, the bronchi constrict, they get really tight. This relaxes them, so that causes the dilation. This is given IV for acute asthma exacerbation. Obviously, magnesium is used in a bunch of other ways, most significantly for hypomagnesemia, which we are not talking about today. If a patient is getting magnesium for acute asthma exacerbation, again, this is IV, this is acute right now, this patient does need to be assessed for magnesium toxicity. We talk more about that in the reproductive health video, where they more commonly use magnesium. But just to mention it here, if a patient's getting IV magnesium, you do need to assess every 15 minutes or whatever the parameters are, their DTRs, their deep tendon reflexes, and their respirations. Because this is a very potent muscle relaxant, it can relax the heck out of your lungs to the point that they stop breathing, which is why you need to monitor this very closely. Let's move on. Now we only have left some chronic medications. Magnesium was the last acute one. Let's go back to the chronic. Again, you can go back to the beginning of these notes and you'll see the list of emergency, meaning acute medications, versus the chronic, meaning long-term medications. And definitely check off each one. Make sure you're very clear on what's what, because the test is for sure going to ask you which of the following will be appropriate for acute versus chronic in some scenario base that you would have to know. Let's move on to methylxanthines. Methylxanthines is one of the most commonly used drugs on the planet. Why? Because caffeine is a methylxanthine. So the drug that we're going to talk about is theophylline. Theophylline is not used a whole lot. Why? Because it is the same drug class as caffeine, so it has all the caffeine side effects. I'm going to jump ahead to that. The side effects are insomnia, headache, palpitations, tachycardia, all the things that we associate caffeine with. Why? Because this is very similar to caffeine. How does it work for asthma? It relaxes the smooth muscle of the bronchi, giving us that bronchodilation, again, fighting the asthma, bronchoconstriction. What do we use this for? As a backup option. This is definitely not a go-to, but it's a backup option for asthma and COPD. This drug is known to have a narrow therapeutic index, so be alert for toxicity, signs of toxicity. Because it is the same as caffeine, excuse me, in many ways, we do need to be alert for dysrhythmias. Patient education, avoid caffeine, as we just said, because this is very similar to caffeine. And this is an oral medication. Pretty much everything we talked about up until now was either inhaled or like magnesium IV. Next, we have the LTRA, the leukotriene receptor antagonist. The drug over here is montelukast, which is singular. The mechanism of action reduces inflammation. Again, that was one of the three problems with asthma. The indications for this, again, this is another one of the three alternative options for chronic management. This is not a go-to drug. However, this is also used for allergic rhinitis, for allergies. Montelukast, or singular, is used for allergies very commonly. In fact, I don't know the statistics, but possibly it's used even more for allergies than it is for asthma. So just keep that in mind. If you see montelukast on a patient's history, that doesn't mean they have asthma. This medication does have a black box warning that it can cause or worsen depression and suicide. So if a patient has a mental health history, especially on a test question, be very careful giving them this drug. Next, we have the mast cell stabilizer, which is cromolyn. Cromolyn reduces inflammation. Again, one of the three problems with asthma. This medication is another one of the three alternative options. So we had cromolyn as a backup, theophylline as a backup, montelukast as a backup. None of these were meant to be primary options. The ICS is still always our go-to for chronic management. The big downside to cromolyn is that it's taken 4 times a day. So we know from fundamentals of pharmacology, the more a patient has to take their medication, the lower their compliance. So if they're taking it 4 times a day, that's a big downside to making sure the patient takes it as prescribed. Finally, we have monoclonal antibodies. Monoclonal antibodies, or MABs, is a drug class that has been around for decades, but it used to just be for things like rheumatoid arthritis. But now monoclonal antibodies are used for tons and tons and tons of different diseases. We talk about this extensively in one of our other pharmacology videos, so I'm not going to get deep into it here. But we do have one that's used for asthma. It's omalizumab. This medication is specifically used for a patient that suffers from trigger-induced asthma, meaning that it's related to inflammation, to histamine or some other mediator. In those cases where it's a trigger-induced asthma, we can treat them chronically with monoclonal antibodies. This is still not an acute medication. This is a chronic medication. Some of the newer textbooks all have this in there already because this has been around for at least 10 years now, I would say. This is a sub-Q medication because it's a monoclonal antibody. All of them are. This does have a black box warning that can cause anaphylaxis. And again, this would never be a go-to option, especially since it's very expensive and it's a shot on a regular basis that nobody likes. But for all those reasons, this is a backup option, but this can be a really good option for a patient that suffers from trigger-reduced asthma to have long-term management. Finally, I don't think you would ever get tested on this in pharmacology, but in real-life nursing world, this is a good thing to know. The ICS, which is our go-to agent, and the LABAs are very often given together. Some of those common medications you're probably familiar with for asthma would be things like Symbicort and Breo and Advair. All of these, I want you to be able to recognize that they are a combination of both a ICS and a LABA, which is classic what we do when we're working our way up. Now, this is not my chart. This was printed by the NIH, National Institute of Health, and I do have the citation down in the references. You can Google this. It's from the Asthma Quick Care Guide. Again, Asthma Quick Care Guide. It's a 7 or 8 page guide that has the latest breakdown on how we manage asthma, and it's written very much that the RN can get to it, even though it includes the physician or provider level guidelines. I just want to go through this real quick, and this is broken down by age. There's 0 to 4, 5 to 11, and then there's the adult. Let's look at the adult real quick. The first thing, if a patient has long-term asthma, we give them a albuterol, a SABA, to use PRN. Hopefully that's enough. However, if they're using it a whole bunch, and by the way, if you Google this guide and you pull it up, it will tell you what's considered using it a bunch. But if a patient's using their inhaler too much, then we add on a low-dose ICS where they take their inhaler every day, morning and night, to hopefully reduce the amount of symptoms that they have. If that's not enough, then we add on, in addition to the low-dose ICS, we add a low-dose ICS with a LABA. That would be like that Symbicort Breo Ellipta we just talked about. If that's not enough, we bump up the dose. If that's not enough, we keep going. This is called the stepwise approach. There are 6 steps. The first step is the inhaler. The last step is where we actually give them oral corticosteroids on a daily basis long term. That's terrible. Hopefully we don't get to that. We want to manage it long before that. Now, again, I want to make sure everyone's clear. The inhaler sticks around through every single step. Every single person who has asthma is going to have inhalers as much as they need to make sure they never get themselves in a bad situation. But we start with inhaler PRN. We add the low-dose ICS. From there, we can add other medications. If you look at the bottom half of this chart, you'll see the theophylline, the montelukast, and those other options we discussed as being there to try grasping at straws. Basically, if our first drugs aren't working, let's add on more, let's add on more. Let's try not to get to all the way step 6 where the patient's on long-term steroids. Here are the references for today's lecture. If you have any questions, please reach out, please subscribe, and like our videos. Have a great day.